Okay. All right. So good morning, everyone. Good morning, very most senior colleagues and colleagues. Well, welcome today to another edition of our YF webinars. And we apologize for starting late. We have Dr. Adebowale here from UCH Ibadan, who will be discussing the complications of trabeculectomy and the management. So, Dr. Adebowale, you can start.
Thank you very much.
Yeah.
So I'll be discussing the topic following this outline as shown, from the introduction to the preoperative evaluation, the overview of surgical steps, complications management, and my references. So glaucoma represents a progressive multifactorial optic neuropathy characterized by the retinal ganglion cell loss and heteroploidy of the optic nerve. And intraocular pressure is a key modifiable risk factor. And as such, the management of glaucoma is often emphasized on optimal IOP reduction in order to prevent or delay disease progression. And this lowering of intraocular pressure can be achieved via medical intervention, laser, or surgical treatment. The trabeculectomy is the most used surgical method when it comes to the majority of ophthalmologists. And it's a filtering surgery in which a fistula is created underneath a partial thickness scleral flap. And aqueous humor flows through this fistula into the subconjunctival space, resulting in a bleb formation with the aim of lowering the intraocular pressure. So a surgical complication is described as any undesirable, unintended, and direct results of a surgical operation affecting a patient, which would not have occurred had the operation gone as well as could be reasonably hoped. And complications in trabeculectomy surgery could occur at any stage of the procedure and even in the post-operative period. So the preoperative evaluation would involve a detailed history taking to involve ocular and systemic history, ocular examination, systemic examinations, and investigations as appropriate. So history would involve the diagnosis, angle closure or open angle glaucoma or any form of secondary glaucoma, because some certain steps or precautions would have to be initiated prior to having the surgery done. For example, in individuals that have neovascular glaucoma, one would want to examine for the presence of rubeosis and then take steps prior to surgery. For example, such an individual may require anti-VEGF injections to regress the vessels prior to having surgery. Or in patients that have ongoing inflammation has to be controlled before surgery. Things like lead infections, blepharitis, and ocular surface disorders, dry eyes, and conjunctivitis will also have to be taken care of prior to the patient having surgery. Then medications that could interfere with the blood aqueous barrier might have to be stopped prior to having surgery, between 1 or 2 weeks before surgery. Latanoprost, brimonidine, and even pilocarpine as well may have to be temporarily stopped prior to having surgery. Now, for the systemic evaluation, it's important to identify individuals that are on anticoagulants or antiplatelet medications, and in consultation with their physicians, these medications might have to be stopped temporarily prior to surgery so as to reduce the risk for intraoperative bleeding. And also patients with hypertension and diabetes also have to have adequate control with a means to reduce the propensity for intraoperative complications, particularly intraoperative bleeding and suprachoroidal hemorrhage. Here is a summary of the steps of the procedure from anesthesia and patient preparation. A bridle suture, a superior rectus bridle suture, although this is not routinely advocated anymore because of the risk of subconjunctival hemorrhage, which might also predispose to scarring later on in the post-operative period. So a corneal traction suture is the one that is more advocated and is more generally commonly practiced now. a superior corneal traction suture around 12 o'clock, about half thickness of the cornea. Because superficial bites would lead to gist wiring, where the suture will pass through the cornea, and the deeper bites might lead to inadvertent anterior chamber entry. Then conjunctival flap creation, depending on the choice of the surgeon, a limbal-based or a phonics-based conjunctival flap is created. But by far, the phonics-based flap is the more commonly used because of the ease of creation and the less risk of post-operative complications. It is also at the point of flap creation that the antimetabolite of choice is being used, either 5-fluorouracil or particularly considering our environment and young individuals and Black patients, mitomycin C is typically used. Now, some individuals would prefer to place the antimetabolite before flap creation or after flap creation, but particularly worthy of note is to ensure that the use of antimetabolites is introduced prior to paracentesis or anterior chamber entry. And paracentesis is created to reform the anterior chamber and also to test for aqueous egress during the procedure, at the end of the procedure. Then the sclerostomy is done, a peripheral ectomy is also done, and then wound closure, both the flap closure and the conjunctival closure. These are the different anesthetic techniques that can be used, local anesthesia particularly. Nerve blocks, particularly facial nerve blocks, would help to control inadvertent squeezing of the eyelids during the procedure. Trabeculectomy will not readily be done under topical anesthesia because of the risk of, well, patients being anxious and lack of cooperation during surgery. Intracameral anesthesia can also be tried, although may not last for the duration of surgery. But by far, the most commonly used is the infiltration, either the peribulbar injection, subtenos, or subconjunctival anesthesia. But then again, the subconjunctival anesthesia also carries the risk of causing subconjunctival hemorrhage, so that may not be routinely used. So this diagram shows the different infiltration techniques, the peribulbar and the retrobulbar anesthesia is not routinely advocated anymore because of the significant risk of retrobulbar hemorrhage. So the peribulbar injection is used, both the superior injection and the inferior injection. And there is the subtenos injection, because the use of a blunt and curved needle which follows the curvature of the globe. This may be advocated, particularly in individuals that have large eyeballs or long axial lengths, where peribulbar anesthesia might cause inadvertent globe perforation. So this picture shows a corneal traction suture that has been placed, and with the traction suture taped down to rotate the globe downwards for easy access. And here is dissection to create the conjunctival flap. Now, what you have noticed is to state that it is advocated to use non-tooth forceps so as to avoid inadvertent conjunctival puncture or tearing, and careful blunt dissection with adequate opening is done. The tenos can be taken as a single dissection or can be done in separate dissection. So the outline of the scleral flap can be done either with a size 11 surgical blade, and then a lamellar dissection is done. A crescent blade, as shown here, can be used, or a size 15 blade can be used to complete the flap creation. So now it is what states that the so relatives to your fluorescing between the different shapes of scleral flap, the triangular flap, a square shaped flap, and the a rectangular flap. By far, the rectangular flap has been shown to have a better posterior flow. But then again, depending on surgeon preference, either the triangular flap or the rectangular flap is commonly created. So this is the antimetabolite being introduced. Now, it's important to state that the antimetabolite is placed in such a way that it avoids the edge of the conjunctival flap itself, so as to encourage proper healing and also to reduce the risk of leaks, particularly at the edge of the conjunctiva after being sutured. Now, this is a flat-tipped instrument. It has a broad base for holding the conjunctiva and also reduces the risk of inadvertent puncture. So the complications from trabeculectomy may be classified by various methods, either related to anesthesia or the surgical procedure itself, maybe intraoperative or postoperative, and there may be anterior segment or posterior segment complications. Now, these are some of the complications, particularly for local anesthesia. What you have noticed is the risk of globe perforation and retrobulbar hemorrhage. Now, globe perforation, particularly with the peribulbar or retrobulbar techniques, and individuals that have high myopia or a high axial length, retrobulbar hemorrhage if the retrobulbar technique is being used. But as I mentioned earlier, the retrobulbar form of anesthesia is not advocated anymore. Then other things such as optic nerve damage and brainstem anesthesia can also occur. Now to the intraoperative complications. This could include conjunctival buttonholing, a subconjunctival hemorrhage, a scleral flap tear, suprachoroidal hemorrhage, lens injury, and Descemet membrane stripping. I will discuss a few of these complications. Now, the conjunctival tear tends to occur during the peritomy and subtenous dissection, and particularly in individuals that have had previous eye surgery, cataract surgery, and as such, there will have been adhesions. This can be prevented preoperatively by the use of topical upperclonidine, as this tends to reduce tissue vascularity and bleeding. Now, the handling of conjunctiva should also be minimized, particularly by ensuring that non-tooth forceps are being used. And for individuals that have thin tissues, it has been recommended that balanced salt solution can be injected under the conjunctiva and tenons in an attempt to make them thicker and easier to handle, what is known as stromal hydration. Now, if the conjunctival tear occurs in settings where the antifibrotic has not yet been applied or was not being planned to use during the surgery itself, it can be repaired by using pulse string bicru suture on a round-bodied needle. Now, because it's a taper point needle, it's not going to cause further injury to the conjunctiva, unlike if a cutting needle is being used. Now, if antimetabolites, particularly mitomycin C, is being used, a patch graft can be done. So a tenous capsule can be dissected and advanced towards the treatment area, and this can be left in place and the surgery can then continue. So bleeding can arise from either the conjunctiva, the sclera, or the iris. And bleeding must be minimized because blood is a potent stimulus for fibrosis and subsequent blood failure. So to prevent this, preoperatively, individuals on anticoagulant medications, antiplatelet medications such as aspirin, or even some herbal remedies such as ginkgo biloba, which some individuals with other forms of optic neuropathy are being placed on, or other general neurologic conditions. And if it's medically feasible, then such medications can be discontinued. So to manage bleeding during the surgery, gentle wet feed diatemy, because excessive diatemy can also cause scleral shrinkage as well. And it's important to also use the lowest possible power setting on the diatemy to help to achieve hemostasis and to prevent tissue shrinkage. Now, the scleral flap damage tends to occur during the flap construction, either before the sclerostomy is done or after sclerostomy, particularly if the scleral flap that was created was too thin. So it's important to avoid a thin flap by ensuring proper depth of dissection, and to also limit the amount of scleral flap manipulation if possible. So if the damage occurs during construction or dissection, it's best to move to a new site to create a new flap. Now, if the flap damage has occurred following sclerostomy creation, this can be repaired with 10-nylon suture, particularly if the damage is minimal. But if the flap cannot be secured, it's important to then use a donor scleral patch graft if available, or processed pericardium may be sewn onto the operation site, and then surgery may then proceed. Now, suprachoroidal hemorrhage occurs when the anterior chamber is suddenly decompressed and shallowed. This particularly tends to arise during sclerotomy creation. So it's important to identify individuals with eyes that may be at risk, such as those with Sturge-Weber syndrome or individuals with large eyes. And also, it's important to stop medications that may provoke bleeding prior to surgery. Now, during the surgical procedure itself, it has been advocated to replace the scleral flap sutures that will be used to close the scleral flap later, such that if there's a sudden anterior chamber collapse, these sutures can be quickly tied up, such as to be able to maintain the anterior chamber immediately using viscoelastics. Now, so the question now arises as to whether to use a sclerostomy punch versus block excision. Different school of thought exists, but some are of the opinion that a sclerostomy punch tends to create smaller sclerostomies, and as such, the risk of sudden anterior chamber shallowing is less, versus if a block excision of the deep block is created. However, this is still dependent on the surgeon's proficiency, as even individuals that are able to create deep blocks by excision tend not to have sudden shallowing of the anterior chamber. But the summary is essentially that one must ensure that there's meticulous surgical technique and careful and steady progress with the surgery to avoid sudden shallowing of the anterior chamber. Now, the choroidal hemorrhage is typically noticed when there's a loss of red reflex, as demonstrated in this picture. Progressively, we can see that the red reflex that was initially visible here has become lost, as the fundus can no longer be readily viewed. So to manage this condition, the wound should be closed rapidly, and conservative care can be instituted if it's located peripherally or if the macula is spared. And if it's extensive, further sclerostomies can be done in an attempt to drain the blood, particularly if the blood has not yet clotted. Now to the post-operative complications. They could be early or late. Early complications, worthy of note, is the shallow anterior chamber and its different causes. Erythema, ocular hypotony, loss of vision, described as a wipeout, and blood-related infections. Late complications such as bleb failure, cataract formation or progression, bleb infection, endophthalmitis, ocular hypotony, and then a symptomatic bleb, also known as bleb dysesthesia. So this algorithm, I'm not sure if shows the intraocular pressure if it's low and high, and the states of the bleb. So if the intraocular pressure is low and there's a presence of a bleb, if the bleb is low of absent, one would think of a bleb leak or a choroidal effusion. And if the bleb is present or a high bleb, that would be an overfiltration. Now, if we have a formed bleb with this setting of a elevated intraocular pressure, this might be due to tight flap sutures or an obstruction of the sclerostomy. But if the bleb is present and the anterior chamber is shallow, one would consider suprachoroidal hemorrhage or malignant glaucoma. And if the anterior chamber is deep and we have a localized bleb, that would suggest a tenon cyst or a ring of steel. And if the bleb is diffuse, that will also suggest a flap resistance. Now, shallow anterior chamber, the shallowing of the anterior chamber can be graded into grade 1 to 3. Either grade 1, where there's peripheral endocorneal touch. This typically can be managed by conservative methods. If there's endocorneal touch at the pupillary border, also described as a pupillocorneal touch, or if there's a grade 3 shallowing where there's lenticulocorneal touch, this is an emergency and needs to be addressed urgently. Now, preoperatively, particularly in individuals that have primary angle closure glaucoma, where the anterior chamber is assessed to be shallow, it's important to do a Redmond-Smith assessment to document the degree of anterior chamber depth in objective terms, and to compare that in the post-operative period, because that will help to monitor the state of the anterior chamber depth. So the Redmond-Smith assessment, the optics, the viewing end of the microscope and the illumination are separated at 60 degrees, and the beam is aligned horizontally. And then the graticle is adjusted until the corneal beam and the beam on the lens and iris surface are aligned. The value obtained is multiplied by 1.1, and the constant of plus 0.5 is then added. Now, depending on the values that are obtained, these are then recorded. So wound leaks is a cause of a shallow anterior chamber in the postoperative period. It is identified by low intraocular pressures, a low lying pleb, and a positive Sidell's test. Now, small wound leaks are often self-limiting, and if leaks are persistent, treatment options could include reduction or discontinuation of topical steroids, with the aim of encouraging healing to take place in an attempt to seal the leaks. Use of a pressure dressing known as a torpedo patching, a wide diameter banded contact lens, or a Simmons shell. And then surgical options such as conjunctival resuturing can be done. Now, this picture shows a torpedo patch being applied. So the patient is asked to look downwards so as to rotate the globe and ensure that the patch is placed on the area of the bleb itself and not on the ocular surface. So a bolster of gauze initially rolled as shown, placed on the closed eyelid, and then further dressings are then applied, and then this is secured and in place. This can be done for up to a period of 2 or 3 days, and then further testing to confirm the anterior chamber being reformed and leakage stopping, and then the Sidell's test later being negative. And this picture shows a Simmons shell, and this outlined area in black is the area that will overlie the bleb, as can be shown here. So the shell has been placed, and then this area is the area over the leaking bleb. This will also help to stop the leakage. Overfiltration is commonly seen in eyes with low scleral rigidity, such as young patients, individuals with collagen abnormality, such as connective tissue disorders, or individuals that have myopia. Is identified by a large bleb and a low IOP, but the Sidell's test is negative in comparison to a bleb leak. Now, this can be prevented by ensuring a tight scleral flap closure and by avoiding thin scleral flaps, which may not provide adequate resistance to aqueous outflow. And then if reducible sutures are used, or even if laser suture lysis will be done, it's important to ensure that these sutures are not released too early, so as to prevent overfiltration. Management is similar to that of bleb leaks, use of aqueous suppressants, the contact lens, and then the Simmons shell. Some individuals have advocated the injection of autologous blood into the bleb area in an attempt to encourage some fibrosis, but studies have shown that the success rate is not that reassuring, and so it's not routinely being done by many ophthalmologists. Now, serous choroidal effusion is common in hypotenuse eyes, and the connection of a high protein-containing fluid in the suprachoroidal space is produced by transudation from leaking capillaries in the capillaries. Conservative management can be instituted, and mediated cycloplegic agents such as atropine can be used, and the frequent use of topical steroids can also be initiated. However, if this fails, surgical intervention may have to be intervened, particularly if there's a grade 3 anterior chamber shallowing, and if the choroidals have been identified to meet in the midline, in the so-called kissing choroidals. Now, pupil block occurs when the peripheral iridectomy becomes non-patent. Either it is inadequately performed or it becomes obstructed by fibrin blood vitreous, or if there is an anterior movement of the iris lens diaphragm. The anterior chamber may become shallow, and the management can include medical treatment to lower the intraocular pressure, the ND-YAG peripheral iridotomy, particularly in individuals that are pseudophakic or aphakic. Now, pupillary dilatation to break any posterior synechia, and then use of topical steroids to reduce inflammatory exudates. Malignant glaucoma, also known as aqueous misdirection. Now, it was historically known as malignant glaucoma because it was found out that if not managed appropriately, it tends to lead to blindness. And it was also observed that initially there was some resistance to medical therapy. But with further advancement and knowledge, this has not been the case. The aqueous is directed posteriorly into the vitreous cavity with a restriction of arterial flow by the anterior hyaloid face. It is identified by a shallow anterior chamber, elevated intraocular pressure. However, in contrast to pupil block, the peripheral iridectomy site is observed to be patent. And also, the degree of shallowing in malignant glaucoma tends to be uniform, unlike in pupil block, where the central pupillary area might still be relatively formed in compared to the periphery. Now, it has been observed that the rotation of the ciliary processes tends to press against the left equator, and this prevents anterior aqueous flow. The initial management of malignant glaucoma involves the use of mydriatic cycloplegic agents such as atropine. Now, what this does is to reposition the iris lens diaphragm more posteriorly so as to allow the anterior chamber space to be better formed. And even intraoperatively, or even at the end of surgery before patient leaves theater, drops of atropine might actually be instilled in an attempt to tighten the ciliary ring and then hold the iris lens diaphragm in position to prevent postoperative shallowing. However, if medical treatment is unsuccessful, particularly after a period of about 72 hours, laser or surgical interventions can be used. Now, the laser interventions are easier to be performed in those that are pseudophakic or aphakic, because in those that still have a lens, there's a risk of cataract formation. But if one does not have a choice, one will still have to go ahead to use the ND-YAG laser or surgical interventions. Now, the surgical interventions can either be the iridozonulohyaloidotomy, where the vitrector can be passed either through the anterior chamber, anterior approach via the cornea, or a posterior approach through the pars plana, in an attempt to free the anterior hyaloid face and allow the trapped aqueous to flow more anteriorly. Or even a pars plana vitrectomy might also be considered as an option. Blebitis and endophthalmitis are potentially blinding emergencies. Blebitis is a spectrum that can be graded into grade 1, 2, and 3. Grade 1 blebitis is infection and inflammation limited to the bleb area or within the bleb itself, where there is a collection of exudates either around the bleb or within the bleb. And grade 2, when there's anterior chamber activity. And then grade 3, when there's vitreous involvement and there's no view of the posterior segment. Now, prevention of early infection is by identification of high-risk patients, particularly those that have conditions such as blepharitis, and this should be managed and treated preoperatively before surgery. Now, intraoperatively, the use of povidone iodine to prepare the skin, the eyelids, the eyelashes, and the conjunctival fornices, and while draping to ensure that the eyelashes are tucked away from the ocular surface. Now, late infections are prevented by avoiding blebs with poor or cystic morphology. It's also important to avoid excessive treatment with antifibrotic agents because this has been shown to predispose to bleb leaks later on in the post-operative period, and this can also predispose to blebitis or endophthalmitis. It's also important to avoid thin scleral flaps, which can predispose to flap necrosis, especially if antimetabolites such as mitomycin C has been used. Now, management is with topical and systemic antibiotics, particularly topical antibiotics with good ocular penetration, such as the fluoroquinolones, particularly preservative-free moxifloxacin, and systemic antibiotics such as intravenous ciprofloxacin can also be included in treatment. Now, aqueous and vitreous taps must be performed and sent for cultures. However, even if there are negative cultures, intravitreal antibiotics should also be given because of the fact that they are directly placed in the vitreal cavity, and that can help to control any infection and inflammation that is ongoing. Now, the vitrectomy should be considered to debulk the infective agents and to also clear the toxins, and also to facilitate better penetration of the medications that have been instilled, particularly the intravitreal antibiotics. Vancomycin 1 milligram is 0.1 ml, and ceftazidime 2.25 milligram is 0.1 ml are typically used. And these medications can be reconstituted in the post-operative period following the intravitreal injections as 50 milligram per ml or 5%. So Haemophilus and Streptococcus are the commonest organisms causing bleb-related endophthalmitis, and as such, they should be covered by the antibiotic regimen. Subconjunctival fibrosis is an important factor in bleb failure, because previously functioning blebs may become encapsulated due to fibrosis. And these blebs tend to appear elevated, tense, and often dome-shaped. Patients previously using topical sympathomimetic agents may have higher risk of bleb encapsulation. And subconjunctival fibrosis is prevented by adjuvant antifibrotics as well as the use of post-operative topical steroids. And in individuals that have had trabeculectomy surgery, they can be on topical steroids for up to a 3-month period. And this is to ensure that fibrosis does not occur and that inflammation and vascularity does not happen around the bleb area. Now, when treating with mitomycin C in the intraoperative phase, it's important to ensure that the area of treatment is over a wide area and not just over some localized area in the subconjunctival bed, because this can predispose to focal bleb leaks and even possibility of fibrosis. Now, management includes subconjunctival antimetabolites, commonly 5-fluorouracil at a concentration of 5 milligram in 0.1 ml. That is 0.1 ml of the 50 milligram per ml 5-fluorouracil that is commonly commercially available. And also subconjunctival mitomycin C may also be used at a concentration of 0.4 milligram per ml. This picture shows a bleb with surrounding area of limitation, as can be seen here. We can also see that it is avascular and it's also a thin walled bleb. So this picture shows the procedure for bleb needling. Now, this is the posteriormost limit of the bleb. So the needle is introduced beyond that area so as to prevent inadvertent leakage, and then advanced and swept in the subconjunctival space to break up the fibrotic tissue, and can even be advanced under the scleral flap itself to also break any fibrotic tissue that might have formed. The procedure for needling may be repeated up to 3 or 5 times as determined by the physician managing the patient. And if all of this fails, there may be need for a bleb revision or a consideration for another procedure, such as a glaucoma drainage device. Now, cataract formation or progression may occur either due to lens corneal touch as a complication of a shallow anterior chamber from all of the causes that have been previously mentioned, either from inadvertent lens trauma during the procedure, for example, during paracentesis or any of the other steps of the surgery, from uncontrolled inflammation, ocular hypotony, use of intraoperative mitomycin C, as well as even the risk of cataract formation following prolonged steroid use, which most patients after trabeculectomy tend to be on steroids for up to 3 months or longer than that. Of course, management for cataracts is surgical intervention, particularly for these patients. Phaco emulsification surgery is usually recommended. However, if this is not readily available, a temporary approach to a small incision cataract surgery with a posterior chamber intraocular lens can be done. Normally, patients that have had trabeculectomy surgery don't typically experience the presence of the bleb there. However, for individuals with large blebs, they may start having foreign body irritation, sensation, and ocular surface irritation. And so for these individuals, they can be placed on preservative-free artificial tears, or if this persists, compression sutures may be placed within the bleb. Now, this picture, I'm not sure if it is clear. I'm sorry about picture quality, but this is the area of the bleb, this area outlined, and this is a compression suture that has been placed around it. That is here and here. These sutures are placed using non-absorbable sutures such as tenuline. So to conclude, trabeculectomy surgery is a first-line surgical option of choice in management of glaucoma, especially in the setting of failed medical therapy or non-tolerance to medications. Complications can be prevented by adequate preoperative evaluation and modification to treatment regimen as needed, and identification of at-risk patients, as well as the intraoperative meticulous and careful surgical techniques, and quick identification of complications and prompt management should be instituted so as to prevent post-operative poor visual sequelae and outcome. Here are my references. There's a link for some videos to some of the still pictures that I took, which we can also look at our free time. Thank you for listening.
Thank you very much, Dr. Adebowale, for that deep and insightful lecture and discussion as well. So we'll take comments and questions now. You can also post your questions and comments in the chat box for our presenter to address. And also, we would also appreciate practical feedback, especially from our very senior colleagues who have had one or two experiences managing complications from trabeculectomy. Thank you very much again, Dr. Adebowale, for that presentation. Okay, so I have a question here. Thank you, Dr. Odera. So, Dr. Ra was asking, what is a conjunctival buttonhole? So, Dr. Adebowale, perhaps you can elaborate more on that while we await other comments and feedback.
Okay, thank you very much. So commonly during the process of trying to create a conjunctival flap, now the idea is to start radial dissections and then carefully separate the tenons and the conjunctiva away from the limbus and from the sclera. However, if the instrument tip, typically a Westcott scissors, for example, inadvertently pierces the conjunctiva away from the limbal area where the initial dissection was started, that is a conjunctival buttonholing. Now, if it's small, it might be missed, and this might cause a wound leak in the post-operative period. But carefully examining the ocular surface during surgery, one may be able to identify such a buttonhole. So that is essentially how a conjunctival buttonhole happens.
Okay, all right, thank you so much. I hope that has clarified the question. So we have some other comments, and we have a comment who says, please throw more light on the surgical management of malignant glaucoma. So would you want to answer everything together, or we take them one after the other? I have a couple of questions there.
Okay.
So let me just read two more, and then maybe
Okay.
you take those three together. And
Okay.
also, for subconjunctival injections of either mitomycin C or 5-FU, post-operatively, the question. So this person's asking, in the instance of a failed bleb, at what location would you want to give the injection? And then the last question we'll take for this round is the torpedo patch also the same as cigarette rolling?
Okay.
So we have the torpedo patch as cigarette rolling, location for 5-FU, post-op in failed blebs, and also shedding more light on the surgical management of malignant glaucoma.
Okay. Okay, torpedo patch. Thank you very much. So for the surgical management for malignant glaucoma, so there are two procedures basically that have been documented. First is the one that they described as the zonulohyaloidotomy, wherein by using a vitrector cutter, the zonus, there's an entry through the lens zonus and then through the anterior hyaloid face. So what this tends to do is to help to separate and remove the anterior hyaloid such that the aqueous that's collected as pockets in the anterior hyaloid face can have room to pass through the anterior chamber and then can then be reabsorbed into the bleb and the episcleral this systemic circulation. So that is what is the iridozonulohyaloidotomy. While if this fails, then a curved vitrectomy via the pars plana approach might then have to be carried out, also with the attempt to clear the vitreous and also remove the collection of the aqueous. Because what essentially happens is that because of the trapped aqueous behind the lens, there's a reposition of the iris lens diaphragm anteriorly, and that is what causes the shallowing of the anterior chamber. So once the aqueous pocket has been cleared and the vitreous has also been cleared, this allows the lens iris diaphragm to fall back, and then this also eliminates the shallowing of the anterior chamber. For the location for injection of the antimetabolite for bleb needling. So well, the idea is that on examination, one will have seen the posterior limit of the bleb superiorly. So about 4 millimeters to 5 millimeters beyond that point, the needle, typically a 23 gauge hypodermic needle, can be introduced. Now, the reason why one has to move a little behind from the limit of the bleb area is to prevent inadvertent bleb injury and then subsequent bleb leaks in the period following the procedure. So the antimetabolites will be injected and then sweeping motions are then done in an attempt to break free any fibrotic tissue that has been formed in the subconjunctival space, as well as in the area surrounding the scleral flap, with care to be taken not to inadvertently puncture the flap or the overlying bleb. Now, the torpedo patch and cigarette rolling, I'm not familiar as to whether that is an alternate nomenclature for the torpedo patching, but I guess I can find out. But Commonly, it is typically referred to as a torpedo patch.
Thank you very much, Dr. Adebowale. So additional comments here. So Dr. Amanda says, can you please throw more light on hypotonic maculopathy as a post-op complication and how it's managed? And then also, thank you, Dr. Ogunbi. He also had an additional comment here, and he says that he appreciates emphasis on the fact that you mentioned pre-op elevated IOP being an ocular risk factor for suprachoroidal hemorrhage, as this can suddenly increase. So as this can increase the risk of sudden AC decompression. So other risk factors, he said, secondly, blood sugar control, also important to reduce bleb-related infections. And then also he says post-op elevated IOP can also result from clots, iris, vitreous plugging the fistula. Thank you, sir, Dr. Ubi, for this additional wonderful comments. So the last question we'll take now before another round is, what is the role of releasable sutures in titrating the intraocular pressure after surgery?
Okay. Thank you. So hypotonic maculopathy occurs in settings where the intraocular pressure falls below 6 millimeters of mercury, and particularly if this persists as a long-term complication. It's commonly identified as a drop in visual acuity, and then on examination, one might identify folds in the choroid, particularly in the region of the macula. Conservative measures can actually help to resolve the condition. But then again, if it doesn't resolve, it's a common cause of poor vision in the post-operative period. Typically, the use of topical steroids and psychoplegics with the aim of helping to resolve any ongoing inflammation that might cause maybe a ciliary body shutdown and subsequent hypotony, and also identifying and managing other causes of hypotony has been mentioned, either from bleb leaks, overfiltration, so as to prevent this complication from occurring. Now, the role of releasable sutures in titrating intraocular pressure. During the surgical procedure itself, depending on the surgeon's choice, they may put permanent flap sutures or releasable sutures, as the case may be. However, for individuals that have had releasable sutures inserted, in the initial post-operative period, the intraocular pressure might be slightly elevated. And as such, one will have to strike a balance between trying to reduce the intraocular pressure and balance it with the steroid medications and the post-operative care. So for these individuals, an initial attempt at digital massage while examining the patients under the slit lamp is used. Now, releasable sutures should not be removed too early because of the risk of overfiltration and all the attendant side effects. So in the initial period, ocular massage, gentle ocular massage, particularly by the surgeon or the ophthalmologist that is managing the patient under the slit lamp with direct visualization to check for the bleb integrity and also the anterior chamber depth, and then careful monitoring of the intraocular pressure. Reusable sutures tend to be released within 1 to 2 weeks after surgery, when the wound healing process and the ocular surface and the healing is getting more stable, such that when the intraocular pressure is now being observed to remain elevated beyond what one targets. Typically, the target postoperatively for IOP control following trabeculectomy is in single digits or the low teens, pressures between 6 to about 10 or 11. Now, so if one is getting pressures that are higher than this, then the reducible sutures can then be removed at the slit lamp. The technique of placing the reducible suture also makes it easy for it to be removed at the slit lamp. So one would not have to take the patient to theater to do that. So the idea is initial regulation of intraocular pressure, digital ocular massage, gentle massage, and then subsequently, when the healing process has become stabilized, the releasable sutures can then be removed if the intraocular pressure is higher than what one expects.
All right, thank you very much. So we have some other comments, and I'll take one of them from Dr. Victoria. So she asked, please, any difference between wound leak and bleb leak? And also we have another question here from Dr. Joseph. It says the procedure, okay, thanks for the presentation. The procedure involves both phonics base and limber base. So I guess this is just a comment. And then last for now, we have a comment also. There's room for adrenaline-free anesthetic agents during peribulbar or subtenon block to prevent further compromise to the optic nerve head, such as wipeout, especially in advanced glaucoma. Thank you, Dr. Eunice Chijoke. So maybe you take that other question about difference between the wound leak and the bleb leak, if there's any difference.
Okay, thank you. So yes, for the adrenaline-free anesthetic agents, yes, that's very true. Also because of the side effect of adrenaline, which is pupillary dilatation. If the pupil dilates, one may find it difficult to be able to do a peripheral iridotomy. So yes, it should actually be adrenaline-free anesthesia that should be used. But to facilitate ocular penetration, hyaluronidase can be included with the lidocaine that is being used to facilitate penetration. Now, as regards wound leak and bleb leak, well, both statements tend to be used interchangeably, but I will state that perhaps a wound leak might be more encompassing to include leakage from any of the other sources, whether from the paracentesis site or from the area of the scleral flap, as opposed to a bleb leak that would be from the area of the bleb itself, either at the level of the limbus or from beyond on the surface of the bleb, either from a conjunctival buttonholing. But by and large, those both terms tend to be used interchangeably.
Okay, so I think that's all the comments and questions we have on the chat box. Thank you so much again, Dr. Adebowale. It's been a very elaborate discussion we have here this morning. Do we have any other feedbacks or comments?
Yes, sorry. I really wanted to ask about, since we're still was primary thought, I wanted to know which one carried a greater complication between the liver phase, the funnel phase. Yeah.
Sorry,
Hello,
I did.
Dr. Joseph, please can you probably speak up louder? We couldn't make that.
So I wanted to know which which of the procedure carry a greater rate of complication, like the liver base and the funnel phase. My text message was first. Are you hearing me?
Yes, sir. Please. Okay, you're asking about the rates of complications either with the liver or phonics, if I may.
Okay. Okay. Well, both techniques of conjunctival flap creation have their own advantages and disadvantages. Particularly as regards ease of creation, wound closure, and risk of lower IOP and wound leaks following the procedure. But the limbal base tends to have a higher risk of complications, particularly with bleb leaks, as compared to a phonics-based approach. And also, the limbal-based conjunctival flap tends to limit room for further interventions, particularly if one would need to do something such as a bleb needling, because the region where we would want the globe to be exposed will already be the area where the bleb height might have reached, as opposed to if a phonics-based a phonics-based conjunctival flap was created, because the closure would be at the limbus, so one would have better space posteriorly or superiorly, as the case may be, to be able to carry out interventions. But the reality is that the choice of which approach to use is still dependent on the surgeon. But the most widely used approach is the phonics-based conjunctival flap creation.
Thank you very much, Dr. Adebowale, for this presentation. We appreciate everyone who's been part of this discussion, and because of time and other activities, particularly with the AOC going on, we won't be able to take additional questions. So, Dr. Adebowale, once again, we appreciate your efforts and the time into preparing this presentation. Thank you, everyone, for being part of this discussion. And then till we meet again next time in another, when we have another discussion of exciting topics. Enjoy your weekend, everyone.